Hello everyone, my name is Adrian Wong. I'm a consultant in critical care medicine in King's College Hospital in London. I would like to thank the organisers for inviting me to talk about an area of interest of mine, and that is the use of ultrasound. And in particular, we're going to be talking about the inferior vena cava, or the IVC. So first of all, my declarations of interest. These are some of the organizations I do work for, but I also am currently pursuing a PhD at Bridge University, Brussels. But probably the most important declaration I'm going to have to make is my intellectual bias. And my intellectual bias is that I believe that ultrasound should be used widely, and anyone who's looking after an acutely unwell patient in any shape or form should have some degree of ultrasound abilities and competencies. Because really, you can use ultrasound to do all sorts of different things: evaluate, diagnose, treat, monitor, so on and so forth. So there's lots that we can talk about. But this being the Fluid Academy Day, we're going to be talking about the use of ultrasound with fluids. Take home message one: fluids are drugs. And like all drugs, they have the appropriate dose, appropriate duration, and you need to think about de-escalation, so monitoring, so that all these different fields and areas that you need to be considering when you're prescribing fluid in your fluid management strategies. So let's talk about some general background information then. Things we know that I hope are non-controversial. So intravenous fluids used appropriately are established part of medical practice. That's on the ward, in the emergency department, but also in the intensive care anesthesia practices. But the Finis study, almost 2 decades back now, has shown that in ICU, patients are 50% of patients will be fluid responsive and 50% of patients won't be fluid responsive. And I think we can all agree too little fluid is a bad thing, but equally, too much fluid is a bad thing. And as I said at the start of this talk, we're going to be focusing on the use of ultrasound and giving fluid, the whole concept of fluid responsiveness. Why are we giving fluids to our critically ill patients? Fundamentally, the answer is this: we are trying to give fluids to improve cardiac output. This curve would be familiar to all of you, and the idea is that when you give fluid, you will be on the steep part of the curve and not the flat part of the curve. The steep part of the curve will indicate that you're fluid responsive. So in response to a fluid challenge, your stroke volume increases, as opposed to being fluid non-responsive, where the administration of a fluid challenge does not lead to an increase in stroke volume. So where does the IVC, or the inferior vena cava, come in? You need to make certain assumptions though, and the assumptions as laid out by this chart are: 1. Respiration causes changes in transpulmonary pressure. This change in transpulmonary pressure is then transmitted to the right heart cavities. The change in right heart cavities varies the venous returns, and that changes affects the diameter of the inferior vena cava. That is the logical sequential reason why we think the IVC is useful in terms of fluid management in healthcare. But as I said, so when the patient breathes in the respiratory cycle, the changes in thoracic pressure affects the IVC diameter. And this is just illustrates the difference between a spontaneously breathing patient and a mechanically ventilated patient. The IVC either distends or collapses in response to the changes in pressure, be it positive pressure or negative pressure. But there are obvious limitations to these assumptions because they are assumptions. And I've listed the limitations there in the box below, but I'm going to pick out a few more of them as we talk about why I think the IVC is perhaps less than useful. So why are we using IVC? I've already shown you it makes sense. Ultrasound assessment of the IVC is non-invasive, it's inexpensive, it's reproducible. It really doesn't demand a high level of training. Novice can pick it up fairly easily. And if you look at all the different guidelines and protocols and competencies of focused echocardiography, the assessment of the IVC is always in it. So it's a skill that experts think is relatively easy to pick up. And let's be honest, given the explosion on the use of ultrasound in critical care practice or any acute medical practice, it's almost established that as part of our volume assessment, we will look at the IVC. And this is the sort of picture you're going to get. This is a subcostal view of the inferior vena cava as it drains into right atrium. The patient is breathing, so you can notice the diameter of the IVC, but as well as how it changes in with the respiratory cycle. So those are the two things you can measure. You can measure the absolute diameter, or you can measure the change in diameter. And I've given you the collapsibility index formula, but also the distensibility index formula. And that obviously is dependent on whether the patient is spontaneously breathing or being mechanically ventilated using positive pressure. And this is how you do it. This is using an M mode, which is a beam of ultrasound cutting straight through the inferior vena cava. And it gives you, you can measure the wall-to-wall diameter of the IVC as demonstrated here. And in order for your calculations in terms of changes with the respiratory cycle, you might do something like this one. So the smallest and the largest diameter you can get through the IVC. And as I said, you can watch the IVC collapse with the respiratory cycle or don't collapse. And the idea is that if it's collapsible, it implies a very, very empty system. And when there's a lack of collapsibility, it implies the system is fairly full. And again, just to reiterate, it is part and parcel of what a lot of professional organizations have encouraged. So this is just one example of it from our colleagues in the Cardiology Society, talking about echocardiography and lung ultrasonography for the assessment management of acute heart failure. And if you look at the ECFI organization handbook, the IVC is mentioned several times, and you might find a table such as this one, which correlates IVC diameter with right atrial pressure. Again, there are systematic reviews out there trying to find the value of the IVC diameter changes in predicting fluid responsiveness. And this is a fairly recent one from 2018, which showed that the findings of this study suggest that the changes in IVC diameter perform moderately well in predicting fluid responsiveness in patients with circulatory shock receiving mechanical ventilation. So, fairly straightforward then. The guideline says it, the evidence says it. But I was always cautioned against that. Just some things are just too good to be true. I'm going to illustrate a couple of those points now. Let's take a series of pictures and diagrams. In the center is what we assume the IVC to be, round and circular. But actually, radiological studies have shown that it's more ellipsoid, so more like the picture on the left-hand side. When you image a 3D object with a 2D ultrasound beam, you can obviously cut it in the short axis, like the two images on the left and center of the picture, or you can cut it in the long axis, like the image on the right side of your screen. It's a 2D image of a 3D structure, so you can cut it at multiple points. And so you need to be absolutely sure that your beam of ultrasound is measuring that same point. And that's fundamentally very difficult considering the fact that with respiration, the whole liver, the patient, the body, the IVC, is all moving. So you're trying to maintain a 1 millimeter ultrasound beam at the very same point and not lose sight of the axis. And how do you know you're cutting the same point? Where are you cutting the point? Because the IVC has lots of different structures around it, and with movement, that might make it more difficult to measure. So we know that hepatic veins, amongst other things, the 3 big hepatic veins drain into the IVC. So if you take a step back, there are sorts of technical limitations of what we're trying to achieve. I've already shown you that the point of measurement, if you look at the studies, they're not really consistent, although 2 to 3 centimeters from the entry to the right atrium seems to be measured. I've told you about the difficulties of challenges of making sure that your measurement is completely down the center and perpendicular, because that leads to an off-axis assessment. You're assuming that the IVC is round when actually most CT-guided imaging studies have shown that it's probably ellipsoid or oval in shape. You might take a step back and say, well, I'm not really interested in the absolute millimeter measurement of the IVC. I'm interested in just whether the IVC is big or small, so a qualitative assessment. But with qualitative assessment, there is an inter-rater reliability problem. It's also too simplistic because you know the IVC is flanked by the heart, the lungs, and it sits within the abdomen. So any factors which affect these systems can and will affect the IVC. So just putting a short list together, what else can splint the IVC open? Well, these are some of the examples. The veins ones I picked up here, but if you've got a massive PE, the IVC will be held open and there will be no respiratory variation in the size of the IVC. Equally, there are things that collapses the IVC, such as raised intra-abdominal pressure. If you push very hard with the probe itself, you might compress the IVC, and that's not reflective of what's happening physiologically. So some people might say, well, it's probably safe to give fluids if the IVC is flat, and surely it's bad to give fluids if the IVC is distended. There is no evidence for this. It is a simple assumption, but there is no evidence. So my closing remarks for the IVC before I moved on to a better solution is that it's probably useful, but the evidence is lacking. But what is probably even more useful is the fact that you can do serial measurements. I highly recommend this particular paper by Scott. It's an excellent paper. Fundamentally, being fluid responsive doesn't mean you need to give fluid. You need to ask the question, why? Why are you giving fluids? And therefore, my proposal for a better way of assessment is a multimodal assessment. Because the IVC is just one component of the whole circulatory system. And the more components that you can measure and assess, the better it is. We need to move away from the concept of fluid responsiveness to the concept of fluid tolerance. And if you then break it down to the various different phases of fluid management, resuscitation, optimization, stabilization, and de-escalation that Professor Malbrain has talked about, you soon realize that actually ultrasound can help, because it gives you an idea of when to start fluids, when to stop fluids, when to start fluid removal, and when to stop fluid removal. So unsurprisingly, you can use echocardiography to assess how the pump is doing. These are some standardized view: parasternal short and long axis, apical forward chamber, and the subcostal view. You can also use ultrasound to assess the lung. This is an example of a normal lung with sliding, not much B-lines, compared to these ones, where there are lots and lots of B-lines. So you can then put it all together into a more holistic whole body approach using ultrasound to assess the fluid status, the pump function, tank function, pipe function. That's not the only one. That was the Rush protocol, but there's also this one by Canadian colleagues, and this one I particularly like because it also talks about giving too much fluid and therefore when you need to remove it. You can assess fluid responsiveness using an aortic VTI, such as this one here, and perhaps in the future we'll get better at assessing other organs flows, kidney, liver, the right atrium, not just about the vena cava. You can assess the diastolic dysfunction, which is relatively an advanced skill in critical care ultrasonography, because you can then put it together into the whole concept of assessing venous congestions. And this is just some nice papers and studies from my colleagues in Canada, Philip Roller, and he talks about something called a VEXA score. It's truly excellent. It makes physiological sense. More work needs to be done, but this just summarizes some of the assessments you can do above and beyond just looking at the IVC. So I've said quite a bit in this 15-20-minute talk. There's a lot to take in, but a good starting point, and it's a paper that we've recently published on what skills you need to have as part of your skill set as a critical care or clinician, intensivist. So my take-home message is this: the only reason to give fluid is to increase cardiac output. Just because the patient is fluid responsive doesn't mean you need to give fluid. And just because it's easy to measure the IVC doesn't mean you should. A multimodal assessment is probably best. And with that, I thank you very much for your attention.